Good evening, everyone. This is Yasser Abu Talib from Egypt. Hi, everyone. I'm the chair of the Egyptian Representative Committee of the Royal College back in Egypt, and it gives me a great pleasure to welcome you all on board. Actually, you know well that we have been taking the responsibility of spreading good information and medical improvement in the form of continuous medical education, as we started 3 years ago of spreading this idea through many webinars and many active scientific activity trying to improve the scientific issues based on the basics of the membership of the Royal College of Obstetrics and Gynecology. So today we are going to discuss a very important issue, which is responsible for high maternal mortality and morbidity all over the world. We are trying by all means to improve survival of the women, either during pregnancy or during operative intervention. However, one of the biggest problem facing us nowadays is thrombosis. We know well the commonest time that thrombosis will occur post-operatively, it will be the seventh day. And this might carry a great problem for the person who will develop this problem. However, one of the most dangerous thing is developing of red clot, which will spread all over the body, going to different area, especially to the lung, causes pulmonary embolism with its complication and high mortality. Today, we are going to discuss this issue in details during pregnancy and non-pregnant state, through which we are going to have a presentation from our colleague Muhammad, Amr, and Magid. And it gives me a great pleasure actually to introduce my colleague Sharif Yahya, who will be the moderator of this session. May I take this opportunity to invite you all to our great coming meeting and congress, which is international one, gathering people all over the world, transferring their experiences in the field of obstetrics and gynecology from all over the world. And what's up to date, it will be next December, 2nd and the 3rd December, through which we are going to meet together, all of us, to conduct this session and different scientific activity in intercontinental on the Nile, just to transfer this information to you. It will be between the 2nd and the 3rd day of the beginning of December. This will be followed by a very great ceremony of the Royal College, which will be held in the same hotel, Intercontinental Semiramis, 4th of December. May I take this opportunity as well to advertise many courses which will improve your capability. And I think we are the only organization in the Middle East and nearly all over the world to carry the responsibility of not only conducting courses, but its hands-on courses. Total laparoscopic hysterectomy, urogynecology courses, CTG, robust courses, and fetal medicine courses. One of the most important courses that we are trying to spread it, and it's hands-on. Looking forward to see all of you in Egypt and to participate in our activity. Thank you very much, and may I hand this meeting to our colleague, the moderator, Sharif Yahya, please. Sharif?
Thank you, dear Professor Yasser. It's a pleasure to be here with everyone today. I would like to welcome you all again on behalf of everyone at the ERC. Just following up on what Professor Yasser was saying, just a little bit of more information about our courses. Currently, we have the basic ultrasound course, and that will be starting on the 19th of June. The hysteroscopy course will be on the 19th and 20th of July. Our TLH course is almost full, and that should have been on the 21st and 22nd of July. We also have our robust course, which is acknowledged and accredited by the Royal College itself, as well as the basic practical skills course as well. And those are mandatory for anyone planning to go and work in the UK. And lastly, we have our CTG interpretation course as well. And if you are unable to attend these, you should know that we have the same courses, hopefully again. We'll try to make them happen before our Congress as well in December. So starting us off, we'll be starting with Dr. Amr Nabil. Obviously, he's a member of the Royal College with a PhD and a consultant of obstetrics and gynecology at Ahmed Meher Teaching Hospital, as well as a researcher at the NRC and a founder in many different societies. He'll be talking to us today about the thromboprophylaxis in pregnancy and puerperium. Obviously, this is a very important subject which touches us in our day-to-day practice. And it's so important that the Royal College has 2 Green Top guidelines devoted just towards it.
Thank you so much, dear Dr. Sharif, for the nice introduction. And I'd like also to thank my dear Professor Yasser for the kind invitation and for the continuous support. Good evening, everyone. It's really a great pleasure to be here with you tonight discussing a very important topic, which is thromboprophylaxis in pregnancy and puerperium. So this is our agenda for tonight. Introduction, antenatal risk assessment, postnatal risk assessment, previous VTE and or thrombophilia, notes during labor and important drugs. So we all know that pregnancy is a physiological hypercoagulable state designed to protect women from hemorrhage at delivery with an increase in factors 7, 8, and 10 concentration detectable from 12 weeks, factor 8 elevated in late pregnancy, marked increase in fibrinogen concentrations, decreased fibrinolysis, returns back to normal within 1 hour of delivery of the placenta, increased concentration of FDPs and D-dimers, venous stasis, and compression of pelvic veins. However, this physiological adaptation also increases the risk of VTE, making VTE one of the leading causes of mortality, maternal morbidity and mortality worldwide. The relative risk of VTE in pregnancy increases by 4 to 6 folds. In UK, the incidence of PE is 1 in 10,000 maternities, and the overall VTE risk is 1 to 2 per 1,000 maternities. The risk of VTE increases with gestational age, reaching a maximum just after delivery, the first 3 weeks. The relative risk, the relative risk postpartum is 5 folds higher compared to antepartum. So pregnancy is a risk for VTE. Some women are at significantly higher risk of VTE due to the presence of 1 or more additional risk factors. Evidence shows that about 90% of women who died from PE had identifiable risk factors. Therefore, this highlights the critical importance of recognizing and managing VTE risks during the antenatal care, during labor, postpartum when risk is highest. Proactive risk assessment can save lives. Okay, so let's have some cases. So the first case, she is a 38 years old lady, gravida 5, para 4 with a BMI of 32. She presents to the consultant-led antenatal clinic at 28 weeks with a fetal growth scan, which was normal. She's otherwise fit. Her booking weight is 95 kilograms. She takes routine pregnancy supplements. So in terms of antenatal VTE prophylaxis, which of the following is best suited to her? Can you please write your answer using the Q&A button at the bottom of the page? So we have E, D, E, Okay, so we have many answers here. Let's take another case. A 31-year-old lady, primary gravida, presents at 12 weeks gestation with a twin pregnancy on ICSI. She is a smoker and her body mass index is 29 at booking. On examination, she has bilateral growth veins. Again, in terms of VTE prophylaxis, which of the following is the best suited to her? Sorry. Okay, we have many answers. Most of them are C. Okay. So the last question, 32 years old lady, gravida 2 para 1 with a history of previous C-section. She was admitted for emergency C-section. Her weight is 48 kilogram with a BMI of 21. She's otherwise fit and well. This will be the last one, then going to our presentation. Okay. We have A, E, D, E, A, many answers. Okay. So let's go to our first part, the antenatal risk assessment. All pregnant women should have VTE risk assessment during the antenatal care, or if there is any hospital admission or intercurrent problem happened, again during labor and postnatal when the risk is highest. So there are general rules of VTE prophylaxis, the scoring system. So the RCOG guidelines score the risks, okay? And it calculates the risk at the end of the assessment. For the antenatal patient, if the patient had scored 4 or more, this is a very high risk. So she is for antenatal thromboprophylaxis and 6 weeks postnatal. If the patient had scored 3, then she's for thromboprophylaxis from 28 weeks, not from the beginning of pregnancy like the first one, and for 6 weeks postnatal. If the patient has scored 2 or less, then mobilization and avoidance of dehydration should be enough because she is at low risk. What about the postnatal? The postnatal, the high-risk patients, thromboprophylaxis for 6 weeks. The patient who had scored 2, thromboprophylaxis for 10 days. If score 3 or more, we can extend thromboprophylaxis from 10 days to 6 weeks. And we have temporary prophylaxis, for example, the hospital admission, hyperemesis, or ovarian hyperstimulation syndrome. And this is a nice table in the guideline, the RCOG guideline number 37A, showing the scores. Okay, so this table here shows that the risk factors for VTE, not all the same. We have major risk factors that carries a high risk for VTE and should take score 3 or 4. And we have intermediate risk factors that carries lower risk for VTE and it takes score 1 to 2. As you can see here in this table, the highest risk is previous VTE, not related to a major surgery, and it takes score 4 and it colors red. And we have other risk factors colored orange, like previous VTE provoked by a major surgery, takes score 3, known high risk thrombophilia. So the highest risk if the patient had a VTE before or carrying the gene, the high risk thrombophilia. The medical comorbidities like cancer, heart failure, active systemic lupus, erythematosus, all are mentioned in the table. So these are high risk factors, take score 3. And we have intermediate risk factors, and it should take score 1 or 2, like the family history of unprovoked or estrogen-related VTE in the first degree relative, no low risk thrombophilia, age 35 or more, obesity, parity 3 or more, smoker, gross varicose veins, all are risk factors pre-existing. This is before pregnancy. We have obstetric risk factors as well. 3 during pregnancy, preeclampsia, IVF, multiple pregnancy, and 7 during labor according to the mode of delivery. So emergency cesarean section takes score 2. Elective cesarean section takes score 1. And other things that might happen during labor, that like mid-cavity or rotational operative delivery, prolonged labor more than 24 hours, PPH more than 1 liter, preterm birth, stillbirth in current pregnancy. And there are some transient risk factors. Some of them are very important, like any surgical procedure in pregnancy or puerperium, except immediate repair of the perineum, like appendectomy, postpartum sterilization. It's high risk, takes score 3. Hyperemesis, until the hyperemesis resolve, takes score 3. Hyperstimulation, of course, it's a very high risk, takes score 4. And the current systemic infection, immobility, and dehydration. This table is very important and it should be present in all maternity notes, in the labor ward, in the antenatal clinics, postnatal, as it categorizes the risk and guide us how to do according to the risk. This is the antenatal side of the table. So again, if the patient has a high risk for a VTE, like a previous VTE not related to a surgery, this is takes score 4. This should be for antenatal thromboprophylaxis, and a specialist should be involved in the treatment. There are intermediate risk factors, 6. Any one of them present, the patient is for antenatal prophylaxis from 28 weeks or from the beginning of pregnancy if there is other risk factors like hospital admission, single previous VTE related to a major surgery, high-risk thrombophilia, medical comorbidities, any surgical procedures, and the ovarian hyperstimulation syndrome. And the third table here, these are low-risk factors. We count them. Every one of them takes score 1, like obesity, age 35 or more, parity, smoker, and the rest of the table. If we find 4 risk factors, then we will start the thromboprophylaxis from the first trimester. If we find 3 risk factors, we'll start from 28 weeks. And if we have 2 or less, then no need for thromboprophylaxis, and mobilization and avoidance of dehydration should be enough. This is very important as well, the low molecular weight heparin. So the first table shows the dose. So the dose of the low molecular weight heparin is according to the weight of the patient, while the VTE risk assessment according to the BMI. If less than 50 kilogram, the enoxaparin dose should be 20 milligram daily, and equivalent doses deltaparin and tenzaparin. From 50 to 90 kilogram, 40 milligram daily should be enough. 90 to 130, 60 milligram, and the rest of the table. It's very important as well to know the contraindication for low molecular weight heparin. All these tables are in the guideline. If the patient has known bleeding disorders like hemophilia, von Willebrand disease, or acquired coagulopathy, active antenatal postpartum bleeding, if the patient is bleeding, like placenta previa or atomic postpartum, when considered at increased risk of major hemorrhage, thrombocytopenia if less than 75,000 platelet count, acute stroke in previous 4 weeks, severe renal disease, severe liver disease, uncontrolled hypertension. So all these are contraindications or cautions to use the low molecular weight heparin. Okay, so this is our question, the first one, and we have the, This is the first question. 38 years old, gravida 5 para 4, BMI 32, presented to the antenatal clinic at 28 weeks with a fetal gross scan, which is normal, and her weight is 95 kilogram. So for this patient, we have 38 years old, this is one risk factor, para 4, another risk factor, BMI 32, so it's 3 risk factors. 3 risk factors, it should be prophylactic low molecular weight heparin from 28 weeks and the dose according to the weight is 60 milligram OD, so the answer is E. This is the second question we mentioned in the beginning of our presentation. So this patient is primary gravida, 31 years old, 12 weeks, but twin pregnancy, 1 risk factor, IVF, the second risk factor, smoker, 3 risk factors, and bilateral gross varicose veins. So she has 4 risk factors. So she is for low molecular weight heparin antenatal from the beginning of pregnancy, and the dose according to her weight should be 40, and the answer, right answer is A. The postnatal risk assessment, again, this is the second part of the second half of the table. As you can see here, there are high risk for VTE. The first table, any previous VTE, any one requiring antenatal low molecular weight heparin, high risk thrombophilia, low risk thrombophilia with family history. So if you find any one of them, this patient is for 6 weeks postnatal prophylactic low molecular weight heparin. There are intermediate risk factors. Any one of these 5 risk factors, you find one of them, then the patient is at least for 10 days postnatal low molecular weight heparin. Cesarean section in labor, BMI 40 or more, readmission or prolonged admission more than 3 days, any surgical procedure in the periperium, like immediate, except immediate repair of the perineum, and medical comorbidities as mentioned. If you find one of them, then at least 10 days of postnatal low molecular weight heparin is indicated. And the last one, the last table is the same as in the antenatal, and the 6 items related to labor are added here, like the preterm delivery, stillbirth, mid-cavity, operative delivery, prolonged labor, PPH more than 1 liter. So the last table, if you find 2 risk factors, so this patient is for at least 10 days low molecular weight heparin. If fewer than 2, then no need for low molecular weight heparin, and early mobilization and avoidance of dehydration should be enough. Again, this is the dosage and the contraindication we should know by heart. Okay, so we have on the right side the table, the postnatal assessment. This patient is a 32 years old, gravida 2 para 1 with a history of previous C-section. She was admitted for emergency C-section. Her weight is 48 kilogram and a BMI of 21. She's otherwise fit and well. So in terms of postnatal VTE prophylaxis, which of the following is best suited for her? Sorry. Okay, so we have some answers. Okay, so the right answer here is D. Why? Because this patient, 32 years old, is not a risk factor. She's para 1 after delivery. It's para 2. She's not a risk factor. But here it was for emergency C-section. And here, emergency C-section, if you read the table, the second one, you find the first item on the second table, cesarean section in labor. So cesarean section in labor takes score 2 and make it intermediate risk. And she's for low molecular weight heparin at least 10 days postnatal. So the right answer is D. And because of her weight, the dose will be 20 milligram. Okay, so we're going to talk about two very important risk factors for VTE. Patient with previous clot and patient with carrying the gene, asymptomatic thrombophilia. This is a very interesting question. Do all women with a history of VTE receive the same management during pregnancy? The answer is no, because we have 4 categories. The first one, single previous VTE related to major surgery. The second one, single previous VTE, but not related to a major surgery. The third one, previous VTE associated with thrombophilia. And the fourth one, recurrent VTE. So starting with the first category, a single previous VTE related to a major surgery. So this patient should take low molecular weight heparin starting from 28 weeks and at least 6 weeks postnatal, but the dosage is the standard dose of thromboprophylaxis and no need to refer this patient to other specialists. So what if it's not related to a major surgery? The risk of recurrence here is high, is 2 to 11%. So we should offer low molecular weight heparin thromboprophylaxis antenatal and for 6 weeks postnatal, not from 28 weeks like the first one, here antenatal and for 6 weeks postnatal. The dosage is a standard dose of thromboprophylaxis and no need to refer this patient to other specialists. The third one is very important. The patient had pulmonary embolism or DVT before, and she carries the gene, the thrombophilia. And the thrombophilia are two types, inherited thrombophilia and acquired thrombophilia, which is the antiphospholipid antibody syndrome. Inherited thrombophilia is a persistent and identifiable hypercoagulable state which increases the risk of VTE. So we have many types of inherited thrombophilia. The antithrombin deficiency, antithrombin 3 deficiency, which carries the highest thrombotic risk. This is the very dangerous. We have protein C deficiency, protein S deficiency, activated protein C resistance. We have factor V leader mutation, which is the commonest type of inherited thrombophilia, which is a common question in the exam. The commonest type of inherited thrombophilia, factor V leader mutation. The highest thrombotic risk, antithrombin 3 deficiency. For factor V leader mutation, it's the commonest one, 6 to 8-fold increase in heterozygous and 30 to 140-fold increase in homozygous. So homozygous factor V leader mutation is carrying a high risk for VTE. We have prothrombin gene mutation and hyperhomocystinemia. So if the patient had previous clot, previous PE or DVT, and associated with inherited thrombophilia, what should we do? If the type of thrombophilia is antithrombin deficiency, this is very dangerous. So she should start low molecular weight heparin antenatal and for 6 weeks postnatal, higher dose of low molecular weight heparin. The standardized dose is not recommended for this patient. So she should take either 50%, 75%, or even full treatment dose. And she should be treated in collaboration with an hematologist. The other heritable thrombophilia defects are lower risk and can be managed with the standard doses of low molecular weight heparin. What about the acquired thrombophilia, the antiphospholipid antibody syndrome? So it might be primary with no other autoimmune disease, secondary associated with systemic lupus erythematosus. How to diagnose antiphospholipid antibody syndrome? The antibodies should be of medium or high titer on 2 occasions, 12 weeks apart, in association with either history of thrombosis or adverse pregnancy outcome, one of the 3 adverse outcomes. So what shall we do if a patient came with previous VTE associated with antiphospholipid antibody syndrome? This patient will often be on long-term oral anticoagulation. So she should start low molecular weight heparin antenatal from the beginning of pregnancy and for 6 weeks postnatal. The dosage, it's not the normal dose of thromboprophylaxis. She should take a higher dose of low molecular weight heparin, either 50%, 75%, or even full treatment dose. And it should be in collaboration with a hematologist or rheumatologist. The last one, the patient had recurrent VTE, like 2 times, 3 times DVT and pulmonary embolism. This patient, of course, should take thromboprophylaxis antenatal and for 6 weeks postnatal, may require higher dose of low molecular weight heparin, and should be in collaboration with an expertise in hemostasis and pregnancy. This patient will be on long-term warfarin or other oral anticoagulants and should change to low molecular weight heparin as soon as pregnancy is confirmed, ideally within 2 weeks of the missed period and before the 6th weeks of pregnancy. This is a very important question. Which woman with prior VTE require thrombophilia testing? All women with prior VTE should be considered for thromboprophylaxis, and hence testing for heritable thrombophilia is not routinely required unless the result will influence recommendations regarding thromboprophylaxis. Okay, so we have two thrombophilia. The dose of thromboprophylaxis is changed. It's like higher dose, the antithrombin deficiency and antiphospholipid antibody syndrome. So we should screen for antithrombin deficiency if the patient had previous VTE and a family history of VTE and either antithrombin deficiency or where the specific thrombophilia hasn't been detected, screening for antiphospholipid antibody syndrome in those with unprovoked VTE. Because we're short of time, we're going to go to the next section, notes during labor. Okay, so the patient is on thromboprophylaxis and she came to labor. When to stop the antenatal low molecular weight heparin? If there's any vaginal bleeding or once labor starts, they shouldn't inject any further low molecular weight heparin. Reassessed on admission and further doses should be prescribed by medical staff. What about the regional techniques? We should avoid any spinal or epidural until at least 12 hours from the prophylactic low molecular weight heparin or 24 hours from the therapeutic dose. Start low molecular weight heparin at least 4 hours after the spinal or removal of the epidural catheter. Epidural catheter shouldn't be removed within 12 hours of the most recent injection. So what if the patient at higher risk of hemorrhage and she needs thromboprophylaxis postnatal? Like the patient has major APH or coagulopathy or PPH, and she's not we can't give her thromboprophylaxis. We can use anti-embolism stockings, foot impulse devices, or intermittent pneumatic compression devices. Unfractionated heparin may also be considered. Thromboprophylaxis should be started as soon as the immediate risk of hemorrhage is reduced. The last section, important drugs. The low molecular weight heparin doses depend on, based on the weight, reduced with renal impairment, no need to monitor the platelet count, anti-factor 10 levels not required, monitor not required when low molecular weight heparin is used for thromboprophylaxis. Lower doses of low molecular weight heparin if creatinine clearance is less than 30 ml per minute in cases of enoxaparin and deltaparin, or less than 20 ml per minute in case of diazeparin, and of course, it's safe in breastfeeding. And these are the contraindications. Unfractionated heparin. We can use unfractionated heparin peripartum where there is an increased risk of hemorrhage or where regional anesthetic techniques may be required. And that's why, because the shorter half-life of the unfractionated heparin. Although it can increase the risk of heparin-induced thrombocytopenia and osteoporosis. If you use unfractionated heparin after C-section, we should monitor the platelet count every 2 to 3 days from days 4 to 14 or until heparin is stopped. Warfarin use in pregnancy, restricted to the few situations as some women with mechanical heart valves. Of course, it crosses the placenta and it can lead to warfarin embryopathy in 5% of fetuses exposed between 6 and 12 weeks gestation. There is evidence that this incidence is dose dependent if we give more than 5 milligrams per day. However, postnatal, we can convert from low molecular weight heparin to warfarin, usually 5 to 7 days after delivery, and of course, it's safe in breastfeeding. The last slide, danaparoid and fondaparinux should be in conjunction with a consultant hematologist with expertise in hemostasis and pregnancy. Low-dose aspirin not recommended for thromboprophylaxis in obstetric patients. Dextran should be avoided antenatally and intrapartum because of the risk of anaphylactoid reaction. Oral thrombin and factor 10 inhibitors should be avoided in pregnant women. Thank you.
Thank you very much, Dr. Amr. This was a very nice presentation. I do have a couple of questions until we can answer all the questions towards the end. The first question is, where would you lie in the obstetric indications? So for obstetric indications, would you have to increase your clexane dose or anything like that throughout the pregnancy if you have a new factor or if you have new indications to increase the dosage? Or would you refer to a hematologist at that point? Or would it be an obstetrician's decision?
Okay, so for example, if the patient is pregnant and had a VTE, like DVT or pulmonary embolism, I believe that we will discuss with a hematologist the condition. But if the patient developed preeclampsia or varicose veins, then we can adjust
Dosage.
the dosage. Yes. So according to the condition.
Okay, and what about our anesthetist friends? If you're not giving either prophylactic or a therapeutic dose, if you're somewhere in between, we always have problems with our friends, the anesthetists. They always want to upgrade and they always want to treat them as therapeutic. What would you think the proper timing between giving regional anesthesia should be if she's taking, let's say, 50% higher or 75% higher, like you were stating?
It's not. I believe it's an anesthetic decision because he's the one who's giving the regional anesthesia. I mean, the prophylactic dose is 12 hours, the therapeutic dose 24 hours. If like 50% or 75% of the therapeutic dose, I believe to be more safe, the 24 hours. But I will leave this to the anesthetist actually.
Okay. I'm just seeing if we have any quick questions that you can answer. So scoring for gynae patients, we will discuss towards the end as well. What is unprovoked VTE? I think Dr. Amr kind of answered that, but could you please answer it again?
Okay. So we have a VTE. Unprovoked means that it's not related to event, not related to a surgery, not related to estrogen, not related to pregnancy. This is unprovoked. Yeah. So if the patient had VTE not related to a surgery, not related to like combined pills, or this has to be considered that the patient is at high risk of developing VTE during pregnancy and even without pregnancy. This is unprovoked.
Okay, great. So unfortunately, we'll move on and come back to the questions towards the end. So we have a bit of a change in schedule. So we'll be discussing thromboprophylaxis and ART. We are always focused when it comes to obstetrics and gynecology, but unfortunately, ART we keep missing, even though a big chunk of our patients have gone under ART routes, whether through IVF, EGSI, or just induction. And to discuss this further, Dr. Maged Adel Aziz will be discussing it with us. He's the fellow of the Royal CV of very highly decorated different degrees. He's an IVF consultant as well, with an assisted conception and IVF fellowship from King's College and the University of London, with a postgraduate degrees in assisted reproduction at Warwick University in England. So he will be discussing with us hopefully today the thromboprophylaxis and ART. Dr. Maged, if you're ready.
We're talking today about thromboprophylaxis and IVF. Just a very small introduction that IVF pregnancy exhibit approximately double antepartum VTE risk compared to the background risk. And as you can see in the graph, there's definitely an increase in the VTE risk in IVF without OHSS compared to the background risk. And this risk catastrophically multiplies by up to 100-fold in the presence of severe hyperstimulation syndrome. Just a brief background about the pathophysiology of the IVF post-thrombotic state. The ovarian stimulation itself trigger a profound hyperestrogenism, simultaneously driving procoagulant factor synthesis, reducing natural anticoagulant, and inducing vascular endothelial dysfunction. So as you can see in the graph, the ovarian stimulation causes hyperestrogenism, and this upregulates fibrinogen, von Willebrand factor, factor 8 and 10, and D-dimer. And it downregulates the antithrombin 3 and the protein S, and this causes the VT. The evidence gap in prophylaxis efficiency is present because current clinical protocols rely almost entirely on observational data and expert consensus as high-quality randomized controlled trials, specifically when designed to evaluate IVF. Some prophylaxis remain absent. So we definitely need more randomized controlled trial to have a consensus about IVF prophylaxis. Universal low molecular weight prophylaxis is neither clinically justified nor cost-effective due to the low absolute baseline VTE risk, and this mandates a shift toward highly targeted individualized risk factors. So there is no need for low molecular weight prophylaxis for all patients going for IVF. The international guideline concordance and divergence, while major international guideline universally reject universal prophylaxis, they diverge significantly in their risk assessment. Mainly the Sweden Federation or Association of Obstetrician and Gynecologists, the Royal College of Obstetrician and Gynecologists, the ESHRE, and the American Society of Hematology. They all agree that universal prophylaxis is not recommended. The risk assessment tool, according to the Sweden Association of Obstetrician and Gynecologists, mainly depend on cumulative points. The RCOG, it depends on categorical threshold, more than 3 factors. The ESHRE focus on OHSS risk minimization, and the American Society of Hematology mainly focus on the quantitative risk. The OHSS management in all categories, the Swedish group recommended low molecular weight until week 12 plus 6. The Royal College recommended low molecular weight to end of first trimester. The ESHRE recommended protocol modification, and the ASH recommended low molecular weight for severe OHSS. The prophylactic timing, according to the Swedish group, at start of initiation of stimulation. The RCOG recommended start in the first trimester and not applicable to other groups. I thought it's very important to highlight that there is a difference between fresh and frozen thawed embryo transfer in the VTE risk, as the fresh embryo transfer exposes patient to HCG triggers and supraphysiological estrogen, driving an 8 to 9-fold increase in the first trimester VTE risk, whereas the frozen embryo transfer normalized risk to natural conception baseline because there is no the supraphysiological estrogen and the HCG triggers as the fresh cycle. The Swedish group focused, as we said, on the points, and they made a point-based system, dictates precise prophylactic action, escalating from no intervention, which is 1 point, to continuous double dose low molecular weight in very high risk group, demanding preconceptional evaluation. And as you can see, the obesity or age more than 40 is 1 point. When patient has protein S or C deficiency, this means 2 points. The homozygous factor V Leiden is 3 points, and the OHSS is 4 points. For the 1 point group, no thromboprophylaxis is needed. The 2 points, it needs postpartum low molecular weight more than 7 days, and 4 points or more low molecular weight throughout pregnancy and for 6 weeks postpartum. And for the very high risk group, the double dose of low molecular weight and multidisciplinary care. The Royal College also put risk factors category in low risk factors, intermediate risk factors, and high risk factors. The low risk factors, which is family history of unprovoked estrogen-related VTE, known low risk factor of thrombophilia, age more than 35, obesity, parity, smoking, and gross varicose vein. The intermediate risk factors is previous DVT, known high risk thrombophilia, and major medical condition like cancer, heart failure, active SLE, inflammatory bowel disease, nephrotic syndrome. The high risk factor is previous VTE, except provoked by major surgery, and the higher single factor risk category mandates thromboprophylaxis throughout the IVF cycle. The thromboprophylaxis management must be integrated across the 5 distinct phases, like the pre-treatment assessment, stimulation, the pre-retrieval, the post-transfer, the first trimester, and the postpartum. The pre-treatment, as we agreed, it has to have assessment of the risk and plan protocol, and we do not prescribe routine prophylaxis routinely. And the peri-retrieval, we have to withhold morning low molecular weight dose on the retrieval day if she's on any anticoagulant. The post-transfer, we have to initiate immediate low molecular weight if severe OHSS develops. And the first trimester, we have to have the targeted low molecular weight if more than 3 ERC-RCOG factors or more than 2% of the American Society of Hematology threshold. And for the postpartum, we have to apply duration guideline based on the cumulative score. The severe OHSS group is very, very important to have on its own a discussion. And if I want to transmit or to share with you an information or an advice I was given long ago, that in OHSS, patient never forgets thromboprophylaxis because this can save lives. Severe OHSS is a dominant independent VTE risk factors. It mandates immediate low molecular weight initiation that must continue well beyond the symptom resolution, and usually it goes to gestational week 12 and 6 days or 4 weeks post-resolution if not pregnant. So if severe OHSS, usually it's inpatient, the action will be to initiate low molecular weight immediately. And if the patient is pregnant, we have to continue, as we said, till the end of the first trimester. And if the patient is not pregnant, to continue low molecular weight until 4 weeks post-resolution. The pharmacological constraint in ART, the low molecular weight is the exclusive standard of care, as we all agree. The direct oral anticoagulant and the vitamin K antagonists are strictly contraindicated due to teratogenicity and placental transfer. I wanted to touch very briefly about recurrent implantation failure and thrombophilia, and this is a very controversial area. But the recommendation is prescribing empirical low molecular weight to improve implantation rate in RIF patients without concurrent VTE risk factor remain highly controversial and lacks standardized evidence support. To have a precise VTE prediction, we need high-quality randomized controlled trial, and we need maybe to use other dynamic biomarkers like the ADAM S13 enzyme, which give us an idea about the activity of the blood clots, the D-dimer and factor VIII profile, and of course to have a global guideline consensus and harmonizing the different clinical pathway we discussed. At the end, I would like to say that targeted prophylaxis driven by validated risk scoring and intense focus on severe ovarian hyperstimulation reduction maximizes maternal safety and avoids clinical and economic pitfalls of universal anticoagulation. Thank you very much.
Thank you very much, dear Dr. Megid. Until we have a few questions, can I ask you, because of your vast clinical expertise, when it comes to OHSS, you know, the problem with them is we usually have a lot of intrafollicular hemorrhage during pickup.
Yeah.
And a lot of, basically you have a very, very loose basement membrane as well. And you tend to have a lot of free fluid in the abdomen. How comfortable are you starting thromboprophylaxis as soon as the patient's awake?
That's a very, very good question, Dr. Sharif. I'll be happy to I usually transfer it 24 hours after the egg collection. But this has to be if it's my decision, I will stay definitely 24 hours. If she is under a hematologist, I will definitely liaise with him or her, but I would usually recommend 24 hours to be more comfortable, not 12.
Right. And what if you're doing a frozen transfer and you're doing a modified natural cycle for frozen transfer and you give an HCG injection? Would that increase also the risk, and would you give thromboprophylaxis at that point?
I don't think, no, I don't think. But that means sometimes now when people, they are already on recommendation on the Clexane or the Imuran or that on lots of medication from the immunological point of view, and this I don't change usually. But if they are for the frozen embryo transfer, so no egg collection, I would happily start straight away after the transfer, even if they have taken HCG.
Okay, and I think the last point, because it's very common now in Egypt specifically, where do you stand on MTHFR?
I would definitely give prophylaxis 100% after embryo transfer.
Okay, and we're talking all prophylactic doses because someone was
Prophylactic
asking.
dose. Yeah, prophylactic
Okay,
dose,
perfect.
100%.
Right. Thank you very much, Dr. Megid.
Thank you.
Now our last session is thromboprophylaxis in operative gynecology. As we're all aware, when we're talking about obstetrics or fertility, the patients are younger in age. They're generally mobile, a little bit better than the elderly, and as well as the operations themselves being a little bit shorter. So when we're talking about gynecology, I think the risks differ quite a bit. Here to discuss it with us is Dr. Mohammed Hassan. He's a consulting gynecologist, head of the OBGYN department at New Cairo Hospital. He's a board member for the ERC and as well as our treasurer. And he will be discussing thromboprophylaxis in operative gynecology. Mohammed, please go ahead.
It was very interesting to attend the presentation of Dr. Amr Nabil, which is extremely important, and as well as the presentation of Dr. Magid. Despite I'm not an IVF man, but I think Sharif enjoyed a lot. And I'm right, Sharif?
I think it was very interesting.
Yes.
And unfortunately, it's usually forgotten in our day-to-day practice. And the problem is no one's seen patients who unfortunately went through ovarian artery thrombosis or any kind of major thrombotic event after OHSS or IVF. And
actually,
it's usually...
I had a personal experience with one of my friends just
Can
maybe
you
a month
see
ago.
the slides?
Yeah. Thanks, Mariam. Thanks. So keep with me step by step to move from your side, please.
Yes, I'm with you.
So I had an experience a month ago with one of my friends. He asked me to go for a surgery, and it was not that sophisticated one. It was like a vulval cancer, a small ulcer lesion in the left vulva, and then we just went for a local wide excision of the lesion with a safety margin, and it was a little bit easy one. No extensions, no bleeding, and everything was fine. Patient was very thin, and she's non-smoker, non-diabetic, hypertensive, and everything was so great. And then after a week, he called me, and he was transferred to the hospital I worked in. I took a look over her condition, and I discovered that she had an extensive lower limb DVT extending from the external iliac vein to the lower part of popliteal vein. And unfortunately, I requested CTPA, and I discovered that there are some showers in her lungs as well, bilaterally. So I asked him directly, did you offer her some injections, like whatever, Clexane or whatever the injection is? And unfortunately, he confessed that he forgot. So despite there are no risk factors, but I believe that the thromboprophylaxis are extremely important, and they are really protective, while some people are maybe um, afraid a little bit from bleeding. But I believe that the prophylactic dose will never lead to significant bleeding. Otherwise, it will help a lot to protect the patient against the thrombosis. So this is the major point. We talked about thromboprophylaxis in OPS, so we need to talk about thromboprophylaxis in gynecology as well. So simply, we can move. The thromboprophylaxis was explained in the talk article 2023, which was mainly aiming for decreasing the mortality of the cases, as well as decrease the possible associated hospital-acquired thrombosis from the bedridden attitude, lack of mobility, and all of these stuff. And it seems like it has a very important economic impact as well, because prophylaxis is significantly more cost-effective than managing a long-term complication of DVT, either or pulmonary embolism. So what is next? The pathophysiology, all of you knows that. The Virchow's triad, famously consisting of a case of stasis of blood, sometimes when the patient is not moving well, when the patient had a bleeding, for example, so there is some sort of heme concentration, endothelial injury, and hypercoagulable status, which is pregnancy, one of them. Surgeries with stress are one of them. So surgeries is a risk factor. The venous stasis may be due to immobility or pelvic mass obstruction, or a long time lithotomy positioning during vaginal surgeries mainly, maybe a cause. While endothelial injury, the inflammatory response itself during the pelvic dissection and advanced pelvic surgeries is one of the risk factors. And of course, some gynecological hypercoagulable status like malignancy and patients on hormonal therapy, which is always being missed sometimes. So what is the patient-related risk, maybe? So we can just classify the risks into some categories. Number one, the patient-related risk. Maybe the advanced age significantly playing a great role in developing DVTs because of the dehydration of old age people, sometimes the lack of mobility or inability to move, sometimes obesity, which is always a common risk factor, personal risk factor in our work. If the patient had a history of previous DVT and she was somehow examined for either congenital thrombophilia, or she's a well-known case of acquired thrombophilia, like lupus disease or something. Personal history maybe play a role with the family history as well, and other comorbidities like acute active infection and other targeted organ failure. The second risk factors group, rather than the patient-related, is related to the surgery itself. So we can move the slide. Yeah. The procedure, yes, the procedure-related factors. Of course, if we are going to do a simple surgery, it's definitely incompatible with a long time, difficult procedure. So surgical duration is critical in your evaluation. Is this patient really in need for some thromboprophylaxis after the surgery or not? So we believe that more than 90 minutes is considered a risk factor. Of course, the advanced cases of malignancy, whereas there is more extensive procedures, techniques, dissection, bleeding, all of this is considered risk. Malignancy itself considered the risk factor. And what is the type of anesthesia? So with general anesthesia, the risks are higher, definitely, for thromboembolic complication compared to regional one. Next, the VTE incidence by surgical route. So if you are going to do abdominal major surgery, this is the extreme high risk possibility for DVT. While laparoscopic surgeries carries a moderate risk. And finally, the least risk is associated with vaginal procedures. Okay. How can we protect patients? We are always rushing to the low molecular weight heparin and other alternatives, while the mechanical prophylaxis is extremely important. Now, we can summarize the mechanical or medical prophylaxis into, as in picture number 1, the elastic TED stockings, or sometimes is the pneumatic compression, sometimes is mandatory for high-risk surgical cases. The early ambulation, critical for all patients. And don't forget the proper hydration. So mobilization, hydration, and elastic stockings. Then the second line will be the injections. The different types of low molecular weight heparin is considered very safe, especially in the prophylactic doses, particularly enoxaparin, which is very effective, very safe margin of for the side effects, and it's available everywhere. Now, the medical prophylaxis, it's one of the maybe the critical things to be well known, that the enoxaparin dose is depending on the body mass index and the patient's weight. So we believe that average of patients are in the second category, from 50 to 90 kilograms in the gynae. I'm not talking about the obstetrics, because pregnant ladies sometimes in Middle East may be higher than 100 kilograms. So 100 kilograms. So in gynecology, most probably we are dealing with patients in the second category, from 50 kilos to 90 kilograms. And then the standard prophylactic dose, I think, will be ideal, 40 milligram once daily. This is after the surgery to prevent the post-operative possible thromboembolic complications. Well, and then you can increase the dose, 60 milligram in high body mass index patients. Now, what about the high prophylactic dose? I believe this should be for extremely high risk group, and I prefer particularly patients who experienced once before a DVT or a pulmonary embolism. Okay, so this is the top category that I may give them a higher dose, or the maximum possible prophylactic dose post-operatively. Now, sometimes we need maybe an extended care, particularly in oncology strategy. And a part of my work, as I'm dealing daily with malignancies. So for patients undergoing major abdominal or pelvic surgeries for malignancy, I think the low molecular weight heparin should be offered to all of them for 28 days. Okay, so 1 month after the surgery, she should take a prophylactic dose daily. Okay, and I believe as well it improves dramatically the overall outcomes, the suture line, decreasing the risk of infections, because a part of intrapartum infection is intraoperative infection is the hemostasis and all of this stuff. So we should keep eyes on oncologic patients particularly, and don't hesitate to give them the prophylaxis up to 28 days after the surgery. Management of patients on hormonal treatment. One of the most tricky points when patients in the middle age are regularly taking oral pills or any other hormonal treatments, sometimes in postmenopausal age, they are regularly taking kind of HRTs. So you should ask patients to stop the pills 4 weeks at least before major elective surgery. And don't forget to do that. The HRT, oral HRT, should be treated as combined pills, while transdermal HRT, which is not too much popular and familiar here in Egypt, and I believe in Middle East as well, you can just stop it immediately before the surgery, as the transdermal HRT hormonal patch is associated with the lowest possible VTE risks. What about Mirena? I believe it's locally acting, and then there are no risks of VTE, and it's safe to be continued during any surgical procedure. Now, finally, what about the different anticoagulants when it stops before a major gynecological or pelvic surgery? Regarding the antiplatelets group, which is the low-dose aspirin or more powerful product like clopidogrel, 5 to 7 days with clopidogrel, and nowadays there are no need to stop low-dose aspirin unless the surgery is extremely high risk for possible bleeding. And this is a new advice by the NHS and the NICE 2025. So it's an updated information. Before, we believed that we need to stop the a low-dose aspirin because it leads to inactivation of most of platelets. So we need to stop it maybe 3-5 days before a surgery. Now there is no need to stop it. But if you have a major surgery and you believe that there is a huge risk of bleeding, so it's maybe stopped immediately before the surgery itself. What about the group of anti-vitamin K, like warfarin? Warfarin is associated with significant bleeding, particularly if the INR is more than 1.5. So I think the warfarin should be stopped 5 days before any pelvic or abdominal surgery. 5 days. And the patient, because warfarin is offered to cardiac patients on prosthetic valves and so on. So the warfarin is a critical treatment for their lives. I can't stop anticoagulants, but I can shift and I can do bridging. So I will stop the warfarin 5 days, shift the patient on the therapeutic dose of the low molecular weight heparin, and then I can stop the low molecular weight heparin 24 hours in therapeutic dose before the surgery. Once the surgery is finished, I will resume back the warfarin, and I will keep both. And this is very tricky. We should know that. Warfarin takes about 3 days for the full effect. So if the patient resumed on warfarin immediately after the surgery, once we believe that there is no source of significant bleeding, don't stop the therapeutic dose of low molecular weight heparin, because the warfarin is not working yet. So you will expose this patient for 2-3 days without anticoagulants. So keep both of them for 3 days and then stop the low molecular weight heparin. And this is what's called the bridging thromboprophylaxis. The third family is very famous, the heparin family. And then the low molecular weight heparin is safely stopped 12 hours before the surgery if the patient is on the prophylactic dose, while 24 hours considered enough to stop the low molecular weight heparin before the major surgery if the patient is on therapeutic dose. What about the unfractionated heparin, or the well-known name in calheparin? So 24 hours with regular activated partial thromboplastin evaluation, and it should never be more than 1.5 times than normal, considered enough. And there is something very nice with unfractionated heparin, that one of the advantages that even if the patient has some sort of bleeding intraoperatively, and she's on unfractionated heparin, I can give the antidote. Am I right? So the protamine sulfate will be the ideal antidote for unfractionated heparin, while in warfarin case, if the patient is still showing some bleeding points, significant bleeding during the surgery, I can give the patient vitamin K, which is the antidote of warfarin. But the problem with low molecular weight heparin, that there is no antidote. But fortunately, it's it's very safe with a very wide safety margin regarding the bleeding. So we are very happy to use it despite there is no significant antidote against the low molecular weight heparin. The VTE risk assessment journey in operative gynecology, I need all of you to keep eyes on this. The initial assessment and optimization, particularly in the first visit in your clinic. Check the patient's BMI, clear the history, DVT problems, family history, first relative, what happened in previous surgeries, what happened in her previous pregnancies and deliveries. You need to ask a lot of questions for proper evaluation and assessment. And please don't forget to reassess one more time by another surgical member's team at the day of the surgery, okay? If there are any additional notifications happen in the surgery, in the operative room, you should write it down to reevaluate the risk post-operative, like significant bleeding, which is what was not expected, for example, or prolonged surgery, not expected. So you need to write it down for proper reevaluation. The daily review of VT risks on the word, because this is the most conflicting moment. Shall I give the patient an injection or not? The patient had a drain inside her tummy, and the operation was bloody hell, and I'm so much inconfident to give an injection. If the patient 4 to 6 hours post-operatively showed no problems with bleeding, so you can start the prophylactic dose immediately, okay? Don't wait. And then education on science of DVT for all patients, because sometimes we have patients that are not complaining, so she may have some pains in her calves, bilaterally or unilateral, some hotness, redness, inflammation, and they deny that something wrong. So you should educate every patient about possible signs and symptoms associated with DVTs. Next, I finished finally. Oh, I think that. So thank you so much. Thanks. And thanks, Mariam, so much for your help. You saved my neck, by the way. And I think I'm ready for questions, Sharif, if you have any.
Mohammed, thank you very much for a lovely presentation. I think we had a question about, again, the combined pills before the operation. Someone was asking, should she take antiplatelets? So I think it's a matter of mentioning just the time, and should she take antiplatelets or not?
Okay, so we need here to clarify a very critical point. Is the antiplatelets, like low-dose aspirin, considered anticoagulants or not? And this is a critical fact, that the aspirin is not an anticoagulant. The aspirin is preventing a platelet aggregation, but it's not working on the clotting factors. So aspirin, even in pregnancy, and you know that very well, Sharif, that we are giving patients, pregnant ladies, starting from 12 to 16 weeks gestational age, a low-dose aspirin, not for the purpose of coagulation issues, but for preventing other things like, for example, preeclampsia. So aspirin itself is not an anticoagulant. So you can't use the aspirin prior to or post to a major surgery, and you feel very confident that DVTs are never will happen. Okay.
Okay,
So
and
you should
once
work.
we've
Sorry.
and the other question is, once you've done your operation, when should the patient resume her HRT or OCPs?
Yeah, I believe that she can resume the oral hormonal treatment 4 weeks after the surgery. Once the patient is mobile, she's fine, she had the review with her doctors and her team after a surgery, so you can resume, the patient can resume her hormonal pills within 28 days after the surgery.
And you know, now we use a lot of longer acting anticoagulants like apixaban. So what do you advise your patients? Like, how long do you advise them to wait until we actually use we actually go for surgery with apixaban or anything like it?
3 to 5 days.
Yeah.
3 to 5 days is more than enough.
Okay. And you know, sometimes you're worried about the bleeding. Someone was asking, Dr. Hella was asking, what if you start beyond the 24 hours? Is it still risk mitigating, or would you just have lost the window?
You mean if the patient is on low molecular weight heparin, for
No,
example,
if
and
after
stop?
surgery, if after surgery you're supposed to start, but you didn't, you waited more than the first 24 hours to start, would you then use something like mechanical socks and compresses and pneumatic socks and then start after that, or would you say that this boat has sailed?
So this is a very nice question, Sharif. So let's explain this simply. I'm talking from my perspective. So all patients, low risk, high risk patients, OBS, gynae, should be offered the TED stockings, I believe, and at least proper hydration, early mobilization, and removal of all tubes, either the catheter or a drain or anything. This is number one. So if I missed to give the patient a proper anticoagulation within 24 hours after a major surgery, I'm talking about gynae right now, so I will just easily give her the dose next day, and I will ask her, according to the risk, either to keep low molecular weight heparin doses for 10 days or 28 days if it's an oncological case.
And that would bring us to the next question. What would you consider to be a low-risk operation? I think something like a diagnostic surgery, hysteroscopy or laparoscopy would be
Hysteroscopy,
very low risk.
laparoscopy, ovarian cystectomy.
But what if it's a hysteroscopic myomectomy, for instance? Would you require
again,
to do?
No. Okay, let's say that we have major surgeries and moderate risk surgeries. So for hysteroscopy, for example, myomectomy, is it a major surgery? No. But it may turn into a major procedure if you took a lot of time and you are unable to finish the surgery in ideal amount of fluid infusion, and the patient is overloaded. Now you have a major serious condition. I'm right, Sharif? So don't deal with a case like lightly. It's just a hysteroscopy. Hysteroscopy may turn to a major procedure, as well as hysterectomy. Hysterectomy, simple hysterectomy, it should be a bleedless procedure and a rapid procedure within 40 to 60 minutes maximum. Sometimes you may find it very difficult and it takes time, and then you have to change your plan to reschedule it from moderate risk surgery. Now it's a high risk surgery. Okay, that's why the reassessment post-operative one more time with whole medical team is mandatory.
Okay. And do you use the RCOG leaflet for stratifying the risk of surgery, or do you use something else, something like the Caprini score that Dr. Asmat was mentioning?
Yes. Actually, I follow that. And of course, I had the mixture of points in my mind. I know the guidelines, the green top guideline of thromboprophylaxis in pregnancy, acute pulmonary embolism, the leaflets of operative thromboprophylaxis, as well as the TOG article 2023. Actually, it released in November 2022. Okay, so if you are looking to see it or read it, you will find it in the issue of November 2022. So I have a mixture of all of them in my brain, and then I evaluate the case in individualized manner. You know that this is one of the points we discussed before, Sharif, and we should explain this. I like the guidelines and I respect the guidelines, but the customized, individualized manipulations are critical sometimes to build up a very personal, individualized plan of care to the patient. You have the broad lines. I will do 1, 2, 3, 4. Okay. But sometimes I may need to involve a hematologist. So I will. Sometimes I may need to raise up the dose a little bit because the patient is very, very high PMI. So I will do, okay? So I can manipulate, and everyone should know that you, not like me. So don't treat yourself like you're treating me, okay? So individualized management is critical.
All right. So obviously there are lots of more questions that we'll need to answer. So it would be very kind of you to go through the chat and start answering all the questions that
I
are
will.
there. At the end, we'd like to thank everyone for attending. Thank you very much to Dr. Amr, Dr. Muhammad, and as well as Dr. Yasser Abu Talib, obviously, and Dr. Megid, as well as the Marketing House and Sanofi for sponsoring. The other thing, I just want to give you a quick reminder of the courses one more time, that we have the basic ultrasound course, hysteroscopy course, the TLH course, which is probably going to be full by the time you try to register, the robust and basic practical skills course, and the CTG course. And obviously, we'd love to see you all at our yearly Congress, which is going to be on the 2nd and 3rd of December. As well as the pre-Congress and post-Congress courses as well. And at the end of the day, thank you all very much for attending, and we hope you have a very good night.